Hi, good afternoon. Thanks, Betty, for letting us start one time and we'll finish. Thank you, Vikas, for making it very easy for me now because decision making in OSA in a 15-minute talk, I think, is not doing justice to it at all. He's covered quite a bit of it, so I will not dwell in that part of the decision making. So, what I won't be dealing in this talk today is about the palatal surgeries, which he's already covered. I'll purposely not dwell into controversies of dice. It's a huge topic. There is a lot of controversy around dice, and I wouldn't be doing justice to it by just putting that point across and then not going through with it. And we will not be discussing about the dental and maxillofacial parts of OSA treatment. This is how we've evolved with regards to decision making. What were we doing for decision making? We were doing a polysomnography, and since the ENTs were not learning so much about it, we learned more about it. We got into understanding PSGs. We did scopies, we did them either awake scopies, then we went into dice. We were incriminated by saying that dice is not, awake scopies is not good enough, or your dice is not good enough because you're not telling us which level of sleep you are in. So we advanced, we went to do dice with BIS, we did it with advanced dice. We also did interventional dice. And after having these three modalities, we started deciding on treatment accordingly. That's how we've evolved. But it's not so simple because every step of the way, when you're dealing with a patient of OSA, you have decision makings that have to be done. Every step of the way. Starting with doing a sleep study, we've discussed that we need to do the sleep study. We need to know which one to do. And I think the basic take home message there would be that try to aim for a level 1 if you can. And if it's not available to you, at least do not touch without a level 3. So you need to do at least that bare minimum. But at the same time, now again, decision making continues. You get the report back. You have to first figure out, is that an adequate report? Is there a correct report for you to justify your findings on? So there are criteria to tell you that maybe the sleep study was not adequate enough. So you need to know the criteria, whether to rubbish off the sleep study that has been brought back to you, or whether it's really worth assessing. So in short, these criteria will be in the books for you to figure out, but important for your decision making scenario. Then the question of doing an FNLP, and the obvious answer is a yes. That is something which is now not even a question that has to come up. It has to be done. The next step question about doing a dice, whether to do it or not do it, that is a question now. That is the controversy. Then there is a question about in whom do we do it? If at all you're going to do it, in whom do we do it? And when do you do it? Right? Now, these are the important questions that you have to answer yourself. And there's data out there which has been published, which clearly says that your dice does not significantly affect your decision making capacity. Now, having shown you data and evidence, I'd also like to go ahead and say, if I am a lawyer and I am defending somebody, I will bring out defense data. If I'm a lawyer and I'm prosecuting somebody, I will get out prosecution data. So just don't go by data to and fro, because it will all depend on what I'm trying to portray. If I'm prosecuting, I will say dice is very important. If I'm defending, I will say not. So leave that aside. There's a certain rationale that you have to apply. Where would I do that dice? That's the question that you have to answer. So if I have symptoms or sleep study or clinical evaluations which are not correlating, I definitely will want to do a dice. That's something that I will want to do. If it's a previously operated case, definitely I will do a dice, because I really need to know what went wrong if he's come back and it's not helped. But I will always do the dice after I've finished tackling the nose and the nasopharynx, because that's open for me to see. I don't really need to do a dice before that. I'll finish that as a first stage, and then I would do a dice, except for if I'm doing a single staged multi-level. In that case, before I touch the patient, then I will do a dice, because then I need to know what is the entire process. But if I'm only dealing with the nasal and the nasopharyngeal part, I don't need to do the dice at that stage. I can always keep it for later, depending on as is needed. When to do it is a big next question. And you don't do it immediately post-op. This is for medical legal reasons for the youngsters also to understand. You schedule your DICE a day before. You make sure that your patient is told the DICE reports and the patient understands it and is concurring with you in what next treatment. You don't take a patient up for DICE, do a DICE, take a consent from the relatives and go ahead with the surgery. Because in that case, you have already pre-decided your procedure and your DICE is of no use. So you need to be able to justify why you're doing a DICE. And there is a lot of controversy, like I said, where if DICE is not changing my treatment, like if he's already mentioned to you that you're going to do this one procedure, which is already tackling the uh, upper part of the soft palate and tackling the lower part right to the pterygomandibular fossa. So if there's one procedure, the earlier time we had issues with DICE were because you didn't know what procedure to do. Now, if everything is boiling down in coming to separating the lateral wall and lifting up the palate, and you know there is a procedure there that can be done, how does DICE make the difference? So that's just to get you to start thinking. And there is again lots of controversies on that. So the decision on the surgery will be where we do it, meaning what structures, when we do it. This is an extremely important decision that you take. You don't become knife happy and you don't go ahead and tell a patient that you'll be to operate tomorrow if he's willing to do it today. You need to get to an optimal BMI situation because that will help you give better results. Of course, patient logistics will come into the picture depending on anesthetic fitnesses, physician fitnesses, whether he's from city, outside city, etc., etc. And then what to do, we've already decided now the various structures and how we're going to be tackling them. So if it's the nose, I don't need to tell ENT surgeons about turbinate and septoplasty. Vikas has already shown you about turbinates in the morning. You have options available to you to decide between what you have and what you don't. But yes, if you're doing nasal surgery, a CT scan is always recommended because you want to make sure that you're not missing out anything. If you're dealing with bony turbinates, removal makes sense. If you're dealing with only engorged turbinates, volume reduction makes sense. So that's how you've got to take your decision making. When you come to the next structure of salpingopharyngeal folds, the reason why radiofrequency doesn't make sense and coblation makes more sense is because there's less dissipation of energy and you have the carotids just lateral to your SP folds. So even though you're pulling it medially and then inserting, always better to use a coblation because less thermal damage that you can have. Adenoids, options wide open, but consensus generally is towards coblation today. It is one of the best tools that is available for you to be using for adenoidectomy. We've already spoken about whatever we need to do, boundaries and things like that, but you need to be able to justify. Let me tell you this, you should be able to justify the tools that you're using. If you're going to say that I'm going to use a debrider initially and then use a coblation because I have both of them, that's not justifiable just because you have both your tools with you. And if at all you want to use them for your surgeon comfort, don't charge the patient for it. He should not be charged two technologies for the sake of doing one surgery. You also have to consider a very important factor between the bony tissues and the soft tissues. That's where the maxillofacial people will come in, because it's a very obvious decision when there is a bony cage issue, which can be seen visually and then taken further by evaluating it even more in detail with dimensions. But there's a gross look you can make out there's a soft tissue and a bony tissue issue. There's a bony tissue issue. Do not try to get into soft tissue surgeries first because it's not really going to help much. And you have to understand that in such a situation, if you see, and this is something you see clinically, you see a high arched palate. There is no point in doing a nasal surgery for such a patient also because you're not achieving that particular expansion. So what we call as a distraction osteomaxillary expansion. This is something that the MaxFax people will tell you or our dental colleagues will tell you. It's assisted by screws, it's assisted surgically. They'll get into the details, but the idea is this. You expand the nasal floor, gives you a nasal airway opening much better. It also helps a lot in opening the posterior pharyngeal space, which they will explain to you. We all know that UP3 had failed, the classical UP3, and what we need to do for the palates, we already know. Since the lecture is over, I'll skip that and come to the base of tongue. Now we have a kind of a classification where we've decided what are the levels of the base tongue, upper, lower. There's no upper and lower anatomical defined demarcation. It's more of a visual look as to where you know where is the upper base, upper tongue and the lower tongue. And there's a simple logic to it. If you have an upper tongue base issue, it's more accessible through the oral cavity. Whereas if you have something behind, it's obviously more accessible through the neck. So if you look at it from the upper base, tongue base kind of procedures, you have options. You have RF channeling, you have coblation excision of the tongue base, you can do coblation channeling. And if you have it lower, then you use a hyoid suspension. But when we talk about the options that you have for the upper tongue base, your decisions have to be based on certain things. They will have to be based on your patient choice and comfort. More importantly, on your own expertise and training. It's not so simple to do an excision of the tongue base as it may be to do a channeling of either midline or on the sides with an RF coblation. So that's something which is very important. And even after that, you have a certain learning curve to attach the tongue base. It's not something that is very easy for the novice. So these will be your decision making points before you start entering intraorally. If you start doing it via the neck, it's a simple procedure. All of us who do literal small neck work can very well do this procedure, and you can actually check the results of the expansion volumetrically later on. But having said that, keep in mind that the distance between the hyoid and the thyroid cartilage is really not that much. You're going to probably achieve maybe 3, 4, 5 millimeters maximally, and that too of soft tissue expansion of a muscle, which over a period of time will lose its tensile strength. So always keep that in mind when you're counseling and talking to patient with regards to results. Of course, you see an epiglottis like this, it is but understood that you've got to do some kind of a supraglottic epiglottectomy, or you do a bulgarization of the epiglottis. Bulgarization is very simple. The lingual surface of the epiglottis gets bulgarized to the tongue base on the other side, and you will have a nice airway open that can be there. The most important thing that you may have to discuss with your decision making when you're talking to them is, are you going to be doing it single level multi-stage, or are you going to be doing it single stage multi-level? A lot of this decision making will depend on whether your patient is from within town or out of town. A lot of this will depend on whether your patient is willing for multiple admissions and going through multiple admissions over a period of time, because each stage will have to be staged at least 1.5 months apart. It will also depend on whether the patient is insured and is willing to spend that kind of money or not. And if not, it's also better sometimes that if there is a lot of obstructions which you can tackle at a single stage, even if he's from within the city, and it is quite comfortable for you to do it with a lower BMI or a reasonable amount of BMI, it would make sense to get that patient through in one shot. So your decision making on this becomes extremely important as you go along with the patient. And I've told you the criteria on which you base your decisions. And the most common question that gets asked, can I do a nose and palate together? Can I do a nose and tongue base together? Can I do a palate and tongue base together? So for that, you have to understand this concept of one major and two minor. And if you look at the list, a septoplasty is no longer a major surgery, because all of us do it, like, has been said, not correctly most of the time. We have to learn it, but it is a minor procedure, number one. Secondly, more so because post septal surgery, I think 80 to 90% of us, all of us, are no longer packing the nose. We're either using quilting sutures, we're using splints, or sometimes we're just leaving it like that. So if your nose remains open, you can do any kind of surgery with the, so even with a packed nose, okay, just to show you a small little clipping. You do a nasal surgery, you put in a nasopharyngeal airway, you're worried about bleeding, you still put in the Avalon packs on both sides. Very comfortably they go through. And immediate post-op, it is not like the patient will have any great problems because he's got both his nose packed. So you can see the patient immediately post-op on table is so comfortable. But see the patient's BMI, see the selection. Selection has to be right. So what I'm trying to say is nose and palate is not a problem to do together. Nose, tongue base, also not a problem to do together, provided you keep the nose open and there's not much chance of bleeding. So when you understand this concept, one major, two minor, do whatever you want. All channeling procedures come under minor. All channeling, whether it's a channeling of the palate, channeling of the tongue, RF channeling, coblation channeling, turbinoplasty channeling, turbinate channeling, or septoplasty. So one major, two minor. If you understand this concept, it makes life much, much easier for you to plan everything. But in spite of that, you have tough decisions to make sometimes when you have niche practice, like what I do. So here's a guy who comes to me with a very high BMI. He's HIV positive. He's on dialysis. He's not at all happy with PAP therapy because justifiably so, that is what is given to him. And he is on the waiting list for a renal transplant. So decisions can be tough. And the only kind of tough answers that you can give such a person is a tracheostomy. That's the only thing that you can offer him as of now. So decision making is not so simple. It is involved at every step of the way. I'm not covering everything in the interest of time, but important points which will help you start your work. I haven't spoken about dynamic MRI at all. I haven't spoken about quite a few things. I haven't spoken about MaxFact, but I'm trying to give you very clear cut messages where your decision making becomes easy. And this decision making comes from interacting with people who think logically and sensibly. And always remember, nobody remembers your PowerPoint at your funeral. And whatever advice you give your patient in today's date, remember that the patient and relatives understand this very clearly. Thank you. So don't try to give them ideas and things which you think they don't know about. They are very smart in today's date. Thank you very much.
Thank you, Dr. Seemab, for a very informative talk. We will need one more Snorcon as a continuation of this because there's so much to learn on this topic.
That's the reason why I said, but sometimes it's very important to incite the interest, and you can't go on justifying every talk to be a complete talk.
Very
So,
true.
very important to get out the right messages for the people who are wanting to come in.
Right. Thank you so much.
Thank you, sir. Would request you to share a memento with Dr. Bachiram. Hatiram. Thank you.